కార్లో వెళ్ళాలని కాదమ్మా. కార్లో వెళ్ళాలని కాదు. ఈయన ఇక్కడ మొత్తం ఈ పనులన్నీ పెట్టుకుంటే ఈయనకి తిండి ఎవరు చేసి పెడతారు?
నేను 10 రోజులు మా భవన్కి ఏదో అడ్జస్ట్ చేసి ఇంట్రా కూడా
4 రోజులు కుదరదంట ఆయనకి. అలా వస్తానన్నది.
मेरी पढ़ाई करना है केवल रिपोर्टिंग।
सर सर नमस्कार। अरे हेलो।
हाँ कारण नमस्कार गुड इवनिंग।
हाँ सर टिके आ 5 मिनट समस्त जॉइन होला पर हम स्टार्ट करियो सर।
Yeah, we'll wait for. Don't worry.
ओके सर थैंक यू सर। सर
Okay, thank you very
आज
much.
सर्वाणी मैडम अछि काली आपनकर अछि काली
मोर
काली
केबे अछि की?
मोर आपन पहर दिन अछि बोधे।
हाँ मोर 28 रे अछि परा।
हाँ ओके सर सर
काली
आपन
सर्वना हेडे नेक तो?
आज सर्वाणी मैडम अछि।
ओके फाइन। मो
सर
अजित सु बचल तो अजित सु मत कहला जे नहीं, it will start at 7.
नहीं जा आगु कहिदिल रे टिके स्पीच वगैरह आपन टिके देबे आपन टिके वेलकम स्पीच।
हाँ let us go ahead. है we'll wait for another 5 to 10 minutes because there is a good number now. Is 100 students have been joined.
Good evening, Dr. Senapati.
Hi, good evening. Sarvani ma'am, good evening.
Sarvani ma'am.
Good. So, uh, uh, you are reaching on third.
I'm reaching on third night and I will leave on fourth night.
Okay, fine. Fourth
In
night.
the morning on fourth, I think we should spend some time with the FICRO applications.
Yeah.
Whatever we've received so far.
Okay, fine.
We've not
It's
received
good.
too many so far, but whatever we've received, we can just look at those.
Better we can send another information to the members.
Okay, yeah, I'll tell Pooja then. Yeah.
Yes,
okay.
that will better. That's number one.
Okay.
Number two, and we have to give much emphasis for the use of our template.
Okay.
I have already sent information to Dr. Pooja also.
Okay.
She told that yes, she will share it amongst all the speakers.
Okay.
Okay, nice to talk with you. Thank you very much. Faculty like you people are definitely enrich this MPRO program. Good. Thank you.
Duplicate.
Good evening, all. Today we are going to start our MPRO program, mock practicals in radiation oncology. It will cover the long case series as well as it is a 7 days program. 7 days program of OSCE series as well as the long case series. So we have assigned the people to present their talks, and we will moderate. The senior people will moderate, and our ROE president, my respected teacher, Dr. Surendranath Senapati, sir, is he is from Acharya Harior Regional Cancer Center, Cuttack. I request sir to say few words.
Thank you, Dr. Kanu. Dear faculties, students, and friends, it gives me immense pleasure to be the part of this academic program being organized by MPRO team under the leadership of Dr. Kanu Charan Patra and also Ajita Sabinas. This is the second program. So I congratulate Dr. Patra and also Dr. Ajitesh, who have taken so much pain to create such a beautiful platform for the postgraduate students who are the future of our ARI. We, the ARI body, have already approved this course. And my dear students, we have moved from conventional to image guided, stereotaxy, as well as AI assisted precision radiation oncology. However, amidst these technological advances, one principle remains unchanged, that the patient must always remain at the center of our decision. So this is a good platform was designed by Dr. Patra and also Dr. Ajitesh, taking the best mind from our ARI. And in front of today, Dr. Sarvani Ghosh Laskar is there. And the main motto behind this, that our students are working in different centers where the technology are not same or equal. But however, these are the basic things, particularly basic case, which has to be discussed in your exam. Because as a member of the committee of the DNB course, whatever my experience says, that last time with the effort of Dr. Kanu and also Ajitesh, the result was more than 80%. So I congratulate both of them, because once upon a time, it was in our mind that the DNB is very difficult to clear. But definitely the standard of our students has been improved. And particularly, I'll give you the emphasis that once you have to spend your time, because today the response is very good. Around 208 participants have joined. So they have to learn how to present a case and also how to face the examiner. That is very important. And also beside that, the OSCE, because whatever the result that we can go through, but important is OSCE, because OSCE will be marked centrally. So if you do well in OSCE, then there is no issue. So students, remember that your degree is only the beginning of lifelong learning. So the future of oncology belongs to those who can integrate the clinical judgment, has to read the case, then think, analyze, and then response. Only one sentence I can say at the end of my presidential talk, that the knowledge gives confidence, compassion earns trust, and integrity builds a lasting career. So I wish all the students a successful academic journey and congratulate Dr. K.C. Patra, Dr. Ajitesh, and specifically the best mind in this field, the best faculty, the Dr. Kanu and their team has selected. So you can best utilize this program, and I congratulate all of you in advance for the good success in your forthcoming exam. Thank you. Thank you once again.
Thank you, sir.
Thank you, sir.
I request Sarvani madam, who is the madam is the professor in Tata Memorial Hospital, and she is the chairman of ICRO. Madam, please say a few words.
Good evening, everybody, and thank you for this invitation, Dr. Kanu and Dr. Ajitesh. Thank you very much for having me here. I was always very keen on having an examination for our students, simply because I know that the surgeons as well as the medical oncologists have some kind of a forum. So this is a very great initiative by Dr. Kanu and Dr. Ajitesh, has already been said by Dr. Senapati. And we will see how you all perform, and it is good to practice. And at every stage, there is a lot of learning that both the students as well as the teachers have to do. So I hope that we have a great experience this time too. And thank you once again, Kanu and Ajitesh. Thank you very much for the initiative that you've taken. And best of luck to the students, and hope you all do well in your exams. Thank you very much, Kanu. Let's start.
Thank you, ma'am.
Thank you, madam. So we started this program. We created a group called Simplified and Comprehensive Oncology Practice and Education Scope Group. We are running those OSCE WhatsApp groups. We are sending the questions in the morning, and we are putting the answers in the evening, and people are answering across the world. People from US, Mexico, Pakistan, Bangladesh, all people are there in there. So, and we give gold medal, silver medal, and bronze medal at the heroic meeting. And this is our logo. And this is the second program. Last year we did. Now this is the second time we are doing. And this is the schedule and slightly may change because of the availability of some presenter or moderator. So now without any delay, I am starting. And today's case presentation is about CA tongue. Presenter is by Dr. Shalini Devi, and moderator none other than my favorite teacher. She is my teacher at Tata Memorial Hospital when I was there, and Dr. Sarbani Ghosh Laskar Madam. I welcome Dr. Shalini. You start your presentation, and Madam will moderate not during and after the your presentation.
Kanu, just before we begin, I would like to ask somebody, whoever is annotating on the slides, please don't do so, because I know some of the organizers have deleted that, but please don't annotate, because this session is for y'all only. So please don't do that. It's okay to sit quietly for some time and listen to what's happening. Thank you. Yeah, Shalini, you can begin.
Dr. Shalini, you are there?
Yes, sir, I'm there, sir. So is it audible, sir?
Yes, clearly audible. You start your presentation.
Yes, sir. Thank you, ma'am. Thank you, sir, for this wonderful opportunity. So I will start this presentation. So case presentation on carcinoma tongue. Just slides.
Not moving.
It's not moving. 1 second, sir.
Just reset once.
1 second. Sir, is it moving now, sir?
No. I just yeah. Yes. Moving.
So, Mr. X, a 42-year male, a resident from Chennai, a businessman, my profession, and Hindu, belongs to a religion Hindu, comes under a socioeconomic status of a low middle class, according to modified Kuppusamy scale, presented with the complaints of ulcer over right side of tongue for 2 months duration, with difficulty in eating food and speaking for 15 days. So patient was apparently well 2 months back when he noticed an ulcer over right side of tongue, and the ulcer was insidious in onset and gradually progressive in size, and initially it was associated with mild discomfort while eating, and which progressively worsened over time, and it was associated with difficulty in eating and speaking, and the ulcer was associated with pain, and which was intermittent and dull aching in nature and aggravated by mastication and intake of spicy food, and it was relieved with analgesics. Over the following weeks, the ulcer progressively increased in size and was associated with difficulty in speech articulations. So, patient had a history of sharp tooth and no ill-defined dentures or loosening of teeth, and no history of any bleeding from lesion or foul-smelling discharge or bad odor or excessive salivation, and no history of difficulty in chewing, swallowing, or opening of mouth or change in voice, or no history of any ear pain or throat pain. And patient was not associated with any fever, night sweats, weight loss, and loss of appetite. And no metastatic history was present, like cough, chest pain, hemoptysis, and pain abdomen, nausea, vomiting. And not associated with any headache, confusion, or any bone pain. So moving on to past history, and he's a known case of diabetes mellitus for 5 years, and he was on medication, and no history of any hypertension, tuberculosis, asthma, CAD and CVA, and connective tissue disorders, and no history of any previous surgical interventions in the past and dental procedures in past, and no history of any previous malignancies in head and neck region requiring radiation in the past. So the personal history of patient was, he was having a mixed diet and has a history of smoking for 5 years duration, and he quit the smoking 2 months back and 2.5 pack years. And he had no history of any tobacco chewing or alcohol intake or any other substance abuse. And his bladder, bowel functions and sleep and appetite was normal. And patient denies any history of any high-risk sexual behavior. And the family history and no history of any malignancies in any of the family members was present. So summarizing a history, that it is my patient is a 42 years old male, a known smoker, presented with 2 months history of non-healing ulcer in right lateral border of tongue, associated with difficulty in eating and speech articulation, and no other significant history. So I would like to further proceed on with general examination. And patient was examined in a sitting position in a well-lit room and with the ECOG performance score 1. And where patient was well nourished and moderately built. And weight was 56 kg and height was 167 centimeters. And BMI was 20.1 kg per meter square and BSA was 1.61 meter square. And no pallor, cyanosis, clubbing, and generalized lymphadenopathy or dehydration, and patient's vitals were stable. So I further proceed with the local examination, and patient was explained regarding the examination procedure, and verbal consent was taken, and he was then examined in sitting position in a well-lit room, and facial symmetry was assessed and it was maintained, and no visible scars, sinuses, or swelling or ulcer noted over the face or neck, and lip appears normal, and mouth opening was adequate with the inter-incisor distance was more than 35 mm, and dentition was adequate with the sharp tooth which was adjacent to the lesion, and no staining of teeth was present. So on inspection, an ulceroproliferative lesion involving right lateral border, ulceroinfiltrative lesion involving right lateral border of anterior two-third of tongue, which was measuring 3 cross 2 centimeter, and anterior margin was 3 centimeter from tip of the tongue, and posterior extent was 0.5 centimeter from circumvallate papillae, and 0.5 centimeter from midline, and extending to the ventral aspect and not involving the floor of mouth. And the lesion had an irregular margin with the surrounding indurations, and no active bleeding, slug, or necrotic debris was noted. And other subsite of oral cavity like gingivobuccal sulcus, retromolar tigone, buccal mucosa, and gingivolabial sulcus or hard palate was free of disease and no ulceration was noted. And base of tongue was appeared to be normal on inspection, and uvula was in center, and palatal movements was normal, and anterior pillars was appear healthy. On inspection, no visible fullness in the neck was present as well as in the supraclavicular fossa. So further proceeding with palpation, so inspectory findings were confirmed on palpation, and sensation over the face were intact, and there was no evidence of any facial muscle wasting, and no loosening of teeth was felt. On palpation, a ulceroinfiltrative lesion, which was measuring in the tongue of 3 cross 3.5 centimeters over ventral aspect of right lateral border of anterior two-third of tongue, which was 3 centimeter from the tip of the tongue, and posterior extent was 1 centimeter from the circumvallate papillae, and the lesion does not crosses the midline, and the lesion had an irregular margin, and firm indurated base was present. On palpation, the lesion was tender, and no bleeding or any discharge on touch. So lesion was not involving the floor of mouth or any subsides of oral cavity, and tongue mobility was preserved, and there was no fixation of lesion to the adjacent structures, and bimanual palpation did not reveal any extension into floor of mouth. So on palpation of neck there were a level 2 prominent single node was palpable, and which was 1.5 cross 1.5 centimeter, and which was smooth and firm in consistency, smooth surface and firm in consistency with irregular margins, and not adherent to overlying skin or underlying muscle, and clinically no other significant lymphadenopathy could be appreciated. So further, I was proceeding with the systemic examination, and CNS.
1 minute, you're being very fast. This is not the way an exam is taken. You will be stopped even after you've taken history. So is there anything that you've missed out on the history?
History.
What is the modified Kupuswamy scale?
Modified
Said that-
Kupuswamy.
Because you said that the patient is lower middle class according to the modified Kupuswamy scale.
Yes, ma'am. So,
what does it mean?
Modified Kupuswamy scale will be based upon the education of the head of family and occupation of head of family, and as well as income, ma'am. It will be assessed based on.
Yes, income is enough, or do you need to know that income is divided among how many people?
It will be divided. I mean, it should be assessed based on how many people, ma'am.
How many people are dependent on that income, right?
Yes, ma'am. Yes, ma'am.
That is important. Then the other thing that you asked, go back to your slides on what you call, just a minute.
Yes, ma'am.
You talked about, that is one thing, all of you have this habit of asking for history of tuberculosis. Have you asked for that history?
Yes, ma'am, I have asked for the history of tuberculosis.
So what is the nature of a tuberculous ulcer on the tongue?
Ma'am, it will be a painless ulcer, ma'am. A painless
and what is the nature? What kind of an ulcer do you see?
Ma'am, it will be ulcer with an indurated, everted edges will be present, ma'am. The tuberculosis.
So what is the difference between a tuberculous ulcer and a malignant ulcer?
Ma'am, malignant ulcer will be painful and it will be bleeding on.
Really? All malignant ulcers are painful?
If any,
See, that is important for you
yes,
because one is the location and one is the nature of that ulcer on the tongue is important for you to distinguish between a malignant ulcer versus a thing, what do you call a tuberculous ulcer or an ulcer which has been acquired because of any sexually transmitted diseases,
yes, ma'am.
right?
Yes, ma'am.
So that is one thing that all of you need to know. And instead of just mechanically asking the patient for history of tuberculosis, you have to know what is the nature of the ulcer that you're looking for. Yeah?
Yes, yes, ma'am.
What are the 6 S's that are associated with an ulcer on the tongue which can which can prove and lead to a malignant ulcer on the tongue?
I'm smoking, sprit, uh,
Kanu, how does this work? Only the person who's presenting answers, huh? Kanu, just tell me.
Yes, ma'am. Yes, ma'am.
Who answers? Only the person who's presenting?
Usually, because if you ask, everybody starts presenting, background noise will
Fine.
be there.
Yeah, because somebody who calls himself or herself Samsung has answered correctly.
They can reply in chat box, madam.
Okay. Somebody has called this an undermined ulcer with tuberculosis. That is correct. Okay, I don't know who is Samsung. Anyway, then tell me what Shalini. What are the other 6s? You
Yes,
told
ma'am.
me three
Yes.
S's. What
Yes,
are the
ma'am.
other 3 S's?
I'm smoking, sharp tooth, spices, sprit, and syphilis and sunlight, ma'am.
So syphilitic ulcers, do you see them nowadays?
No,
And what is the characteristic of a syphilis ulcer?
ma'am, it will be associated with high risk sexually transmitted diseases, ma'am. And it will be usually painless and having indurated base, and it will be smooth also, ma'am, usually associated with a sexually transmitted infection, and it will be a solitary ulcers, ma'am.
Which stage of syphilis do you see this ulcer?
Tertiary.
Very good. Okay. So, what is the other sexually transmitted disease today that you would look out for? Not in oral cavity, not in tongue, but in other sites in the head and neck? Do you associate oropharyngeal cancers with any sexually? Yes, somebody is now writing. Now, so many people have written HPV. So, you have to know about it. It has to come out fat from you, okay?
Yes, ma'am. Yes, ma'am.
Yeah. So you talked about the 5 S's. Then now next you go. So this patient does not have any sharp teeth, nothing. So what is your impression based on the history of this patient?
Ma'am, as it is a non-healing ulcer, which was present for, which was initially it was is smaller in size, and it was progress to the present size, ma'am, for a past 2 months duration, and it was also associated with difficulty in eating and speaking, ma'am, and it was also associated with the pain. So, but and also he has a significant history of sharp tooth was also present, and no other. No other significant history or metastatic symptoms was present, ma'am. So based on this progressive nature of disease and non-healing also for past 2 months duration, so it can be the malignant nature of malignant ulcer of tongue, ma'am.
So you will call this malignancy because it is what? Give me them 3 or 4 features why this is a malignant ulcer. You've said that it is non-healing.
Yes, ma'am.
It is progressive in nature.
Yes, ma'am.
Is pain a feature of malignancy or not a feature of malignancy?
Yes, ma'am. 1 second, ma'am. Slides.
Forget the slides. You people are too used to slides. Tell me, is malignancy associated with pain or not?
Yes, ma'am. Initially, the malignancies will be painless. Malignant ulcers will be painless, ma'am. And after that, it will be painful, ma'am.
So, what is pain indicative of in a malignant ulcer?
Ma'am, it will be nerve infiltrations will be associated with pain, ma'am. Nerve infiltration
Okay.
in malignant
So
ulcer.
now next you've gone to your examination. So in your
Yes, ma'am.
examination, you've talked about the disease being. Go ahead to your examination. Move your slides.
1 second, ma'am. My slides are not moving. 1 second.
Take it and reshare it again.
1 second, sir. 1 second.
So all of you are correct that the pain that happens afterwards is essentially because of the neurovascular invasion. So nerve invasion can lead to pain later on, but it does not appear initially when the patient presents with a non-healing ulcer. So the reasons in the characteristics in favor of a malignant ulcer on the tongue here are essentially the progressive nature of the lesion, because there is pain which appeared later on, and because this lesion did not respond to any conservative measures. All right. So Shalini, you talked about the lesion being on the lateral border of the tongue.
Yes, ma'am.
Then can you go ahead?
1 second, ma'am. My slides are not moving, ma'am. 1 second, ma'am. I will reshare. 1 second.
You also in the history spoke about there being about there being no referred pain in this patient. Now, where is the referred pain usually felt in patients with carcinoma of the tongue?
Usually in the ear, ma'am. Referred otalgia.
And why does this happen?
Because of when lingual nerve lingual nerve is get affected due to trigeminal ganglion, and auricular temporal nerve will be affected, ma'am. So due to this, referred otalgia will occur, ma'am.
So what will happen? So lingual nerve is a branch of which nerve? Cranial nerve?
Facial nerve, ma'am. Facial nerve, ma'am. Branch of.
Lingual nerve is branch of which nerve now here?
Sorry, ma'am. It will be mandibular nerve, ma'am. Sorry, ma'am.
So Pooja is correct. It's a trigeminal nerve, so fifth nerve. And then it goes to which ganglion and you get pain?
Trigeminal ganglion, and it will be
the Caesarean ganglion. So the ninth nerve and the fifth nerve.
Yes,
that is because of the pain. The other thing that you describe of referred pain is because of the laryngeal cancers, and that is because of the nerve of Arnold's nerve.
Arnold nerve, ma'am. Arnold nerve.
And that is 10th and trigeminal, right?
Yes, ma'am.
So you people need to be very clear about this referred otalgia. Why does it happen in the tongue, and why does it happen in the larynx, and whether the mechanisms or whether the ganglion are different. All right?
Yes,
that is very important. Okay, now go on. Now see, the thing is, mechanically, if you ask for things like difficulty in mouth opening, any bony pains anywhere in the body. Now, difficulty in mouth opening, why? Why do you expect this lesion to have spread, to have difficulty in mouth opening?
Ma'am, in case of if it is a locally advanced disease, if a spread of lesion to the muscles of mastication, infiltration of muscles of mastication.
Right? You've seen this patient. This patient is in front of you.
Yes, ma'am.
So do you think this patient will have difficulty in mouth opening?
No, ma'am. No, ma'am.
Really? And then what about bony pains anywhere in the body?
Ma'am, it is in case of any bone metastasis.
What percentage of lesions like this, which is actually a T1 lesion, of course we don't know the depth of invasion and it's N0. What percentage of these patients will have bone metastasis? And if it is a squamous carcinoma?
It's very less, ma'am. It will be.
So you need to, whenever you ask these questions mechanically, all of you need to be aware of why you are asking the question and the answer to that why. It is very important, because otherwise mechanically you will list a whole, because most of these patients would present with a particular kind of symptom. So Either you get it as a short case most often, or sometimes you get it as a long case very rarely. Otherwise, it gets it as a short case. When you have a short case, you have to give the relevant negative history and relevant positive history. So don't mechanically ask for history of bone pains, because very few patients, especially when it is an N0, will have bone metastasis, especially in squamous carcinoma tongue. Okay?
Yes, ma'am.
Please remember this. Just don't mechanically ask for bone pains. All right?
Sure, ma'am.
Yeah. Next, come on. Next slide. Next slide. Now, why do you ask for history of comorbidities in patients?
Ma'am, to assess the general condition of patients and to start on the management of the patient, to assess the general condition and performance of patient, ma'am.
So I see several answers being written in the group. Some people have written about the immune status of the patient. Some people have written about the ability to plan the management of the patient, and then, of course, to select a patient for treatment. So when you are looking at a patient like this and you spend about an hour or so with a patient like this, you kind of make a decision about how you're going to treat this patient, right? Now, when you make that decision in your head, you also have to think about the evidence to support your decision or not support your decision. All right?
Yes, ma'am.
So that is why you need your comorbidity history to be able to understand what is going to support your decision for management, which means both investigations as well as treatment. All right?
Yes, ma'am.
Okay. Now next, go on. Now you have really asked this patient for history of sexual behavior.
Yes, ma'am. We have asked the patient for history of sexual behaviors, ma'am.
Where is this really important in head and neck cancers?
I mean, in case of oropharyngeal cancers, ma'am.
Why?
Oropharyngeal cancers are associated with HPV infections, ma'am.
So what happens with HPV infection?
Because the prognosis will be better in case of HPV infection, and the staging alterations will be based on HPV. The staging will be altered, ma'am.
So if you are told about the HPV, so how will you test for HPV in this patient?
By P6, in immunohistochemistry, P16 will be done to assess the HPV
When
state.
do you say it is P16 positive versus P16 negative? What do you have to see on the slides? You have to have more than 70% positivity.
In diffuse nuclear and cytoplasmic state.
Yeah, so more than 70%. Yeah, Shubhda has said it right. The other thing is, today, is HPV positivity just determined by P16 positivity? You all just answer yes or no to this question, simply because I don't expect that you all are head and neck experts, but you all should be aware of what has been described to confirm that the patient is HPV positive, not just P16 positive. P16 is a surrogate for HPV positivity. But what is it? Somebody had written about HPV RNA. Yeah, HPV DNA, correct. So in low incidence countries especially, it is important to establish the role of HPV when it is P16 positive or P16 negative, especially by determining the RNA or the PCR from HPV, because you need to know E6, E7 status. Okay, next, then what have you done? So you think this is a 42-year-old male, known smoker, with history, 2 months history of non-healing ulcer in the right lateral border of the tongue, associated with difficulty in eating and speech articulation with no other significant history. And you think this is a malignant, you have called it a non-healing ulcer, but there is a very high probability that this may be a malignant ulcer, right?
Yes, ma'am.
Shalini?
Yes, ma'am.
Because of the reasons that you have explained. All right?
Yes, ma'am.
I may not at times refer to what all of you are writing in the chat box, but remember that I'm seeing what you people are writing. Okay, next, go on. So you've done a general examination, and in the general examination, you've talked about the performance status. I personally prefer the KPS simply because the KPS talks about a 10-point grading, whereas the ECOG performance status actually talks about a 0, 1, 2, 3. Now, in that, actually, it's very wide, and 0, 1, 2, 3 may encompass a lot of morbidity without actually giving it a particular number. So that is one thing. So you people should know about the KPS for performance status also. Well nourished, moderately built, okay. You've written the BMI and the BSA, and no pallor, sinuses, clubbing. And you've talked about the vitals, okay.
Yes,
what is the other vital that is very important which you've not mentioned here? What is the 6th vital sign? The 5th,
pulse, blood pressure, respiratory rate, temperature, and
what is the Edmonton symptom category? Do you have anything else there? Do you have distress?
SpO2, ma'am. SpO2, oxygen saturation.
Distress. Do you have a symptom inventory which has a thermometer or Edmonton, I think what you call symptom thermometer? And of course, pain. Pain is the other thing, someone very importantly has written about.
Yes, ma'am.
Pain. Pain and distress are very important to measuring person. Okay?
Okay, ma'am.
Today we are talking about oxygen dependence and all that because we have gone through the COVID era, but that may or may not be important. You can mention it. If you mention it, of course, you'll get additional points. But then definitely pain as well as distress is another thing that you definitely need to mention. Okay, next thing. So you've talked about facial symmetry, no visible scars, sinus, swelling, or ulcer was noted over the face and neck. Why are you talking about the face and neck? I don't know. Anyway, lips appear normal, mouth opening was adequate with inter-incisor distance of more than 35 millimeter. Now, I would always recommend that you actually measure what is the inter-incisor distance. All right, instead of just saying more than 35 millimeter means nothing to me. The other thing is also what if the patient is edentulous, which you may get in many of these patients? Then what do you measure?
Not audible, ma'am.
Supposing the patient is edentulous, then what do you measure? Anybody? Yes. I think somebody has written correctly. It is the gum distance. So it is the interalveolar distance that you will measure at a particular point. So that is what is important. Next, come on. You need to do this. Why do you need to do it? Because you need to know whether your patient has responded to treatment. If the patient has responded to treatment, after treatment, what is happening? So you need to know all that.
Yes, ma'am.
Okay. So then you've got an ulcero-infiltrative lesion on the right lateral border of the tongue, which is about 3 into 2 centimeters. Anterior margin of the lesion is situated approximately 3 centimeters from the tip. Posterior extent is about 0.5 centimeter anterior to the circumvallate papilla, 0.5 centimeter from the mid and extending to the ventral aspect, has irregular edges with surrounding induration and no active bleeding. So this is on inspection. Then on palpation?
On palpation,
They were confirmed. And what do you think was the depth of invasion?
Depth of invasion cannot be assessed by physical examination.
But you can say whether the lesion is reaching the midline or not reaching the midline, whether it is restricted only to the lateral border of the tongue.
Yes, ma'am.
Right?
Yes, ma'am.
Okay, next, go on ahead. And then what about the edges of the tumor? It has irregular margin and a firm indurated base. The lesion was tender on palpation. There was no bleeding or discharge on touch. Next. Lesion did not involve the floor of mouth, gingiva buccal sulcus, retromolar trigone. Now, how will a patient who has a lesion that's involving the right lateral border of the tongue, not involving the circumvallate papillae, reach the hard palate or base of tongue? Why do you write such things? Please do not write them.
Sure, ma'am.
Because I don't think it is correct if you say that the lesion is at least 1 centimeter or 0.5 centimeter from the circumvallate papillae, unless you think there is submucosal disease and submucosal extension that is going to the base of tongue. Correct?
Okay.
Otherwise, how will the disease extend to all those areas? Same thing about extension to the retromolar trigone as well as extension to the hard palate.
Yes, ma'am.
Then you say that the neck has a level 2 lymph node on the right, left, which side?
It's a left side, ma'am. I mean, it's
How
sorry,
left
ma'am. It's
side
right
is
side, ma'am. It's right side, level 2, enlarged lymph node, ma'am. I forgot.
enlarged lymph node, which was approximately 1.5 into 1.5 centimeter in size, firm in consistency with irregular margins, not adherent to the overlying skin or underlying muscle clinically. So this was mobile, this node.
Yes, ma'am. It was mobile, ma'am. It was mobile node and it was palpable.
So what is your final stage? From your provisional, what is your provisional diagnosis?
My provisional diagnosis is a malignant ulcer of right lateral border of tongue, ma'am. And my clinical staging will be clinically it will be T3 and N1 disease, ma'am. But
how T3 you will say? No, what is your size? Go back to what you've written about the size. It is 3 into 3.5 centimeter.
Yes, ma'am.
So will you call it a T3 or a T2?
Ma'am, based upon the depth of invasion, will be assessing, ma'am.
Where is you told me just now that we cannot assess depth of invasion on clinical evaluation. Now you're bringing in depth of invasion and then calling it a T3. So it is more than 1 centimeter thick, deep. Anna, it has to be more than 1 centimeter if it is 3 centimeters. If it is what you call 3 into 3.5 centimeter, it will actually have to be more than 4 centimeter in dimension, length into breadth, or it will have to be more than 1 centimeter deep, depth of invasion. I can see nothing to make it a T3 lesion. It is a T2, correct?
Yes, ma'am.
Do you agree or not agree?
Yes, ma'am.
So it's a T2 lesion with an N1 node in the neck.
Yes, ma'am.
You think the node is involved?
Yes, ma'am.
All of you have to be very sure of the clinical stage of the tumor. Clinical stage actually includes even the radiology, but we will come to radiology afterwards, okay? But based on your clinical evaluation, it is a T2N1M0, okay? Malignant lesion on the on the right lateral border of the tongue, okay?
Yes,
because there is no ankyloglossia, there is no difficulty in opening the mouth, the tongue is nice and mobile, correct?
Yes, ma'am.
Somebody in the chat had asked whether it is all right to say that there is no other lesion on this. Can we go back to that? I think somebody had written that, and that is a pertinent question. Can we say separately that there is no lesion in the tongue, hard palate, RMT, or buccal mucosa? Yes, you can say it. But why do you want to say this and make a particular mention of this? Can someone tell me the answer to that statement, to that question that I'm asking? Yes. So actually there is an incidence of synchronous second primary or field cancerization in oral cavity tumors. Especially this patient is high risk because he's also a tobacco user. So there is a finite incidence of a second primary or a second synchronous primary or field cancerization in these patients. Now, my advice to all of you is also that you read up the latest ASRs as well as the probability of having a second primary and the attributable risk because of chewed tobacco and smoked tobacco in these high group patients. All right, high risk patients.
Yes, ma'am.
Okay, yeah.
Yes,
So now, so this is a T2N1M0. What next?
Further, I would like to proceed
You
with the
move your slides. You're moving your slides, right?
Yes, yes, ma'am.
Yeah. And then you'll do a systemic evaluation. Okay. Next.
So, so, so I would like to further proceed with the diagnostic workup with the biopsy confirmation or histopathology confirmation, ma'am, of the lesion. And I would proceed with the edge wedge biopsy of the ulcero-infiltrative lesion and with the biopsy of lesion from the anterior edge along with the normal tissue will normal mucosa will be.
The stage you will change. It will be a T2N1. It is still a stage 3. So this is, so what will you do next in this patient?
I would proceed with the biopsy confirmation of the patient, ma'am, histopathological confirmation of diagnosis. So I will proceed with the biopsy of the patient with edge biopsy and with taking anterior edge of the lesion along with the normal mucosa will be taken for the assessment of.
So would you like to first go ahead with a biopsy, or would you like to image this patient first?
Ma'am, mostly if the biopsy does not alters any change, causes any changes in imaging like edema or inflammation, I would proceed with biopsy, ma'am. Or else I will proceed with imaging
What will
first.
you now you're talking theory. You have the patient in front of you. What will you want to do in this patient? Do you want to do imaging or do you want to do a biopsy?
I will do imaging first, ma'am. I will proceed with imaging first and then will proceed with biopsy, ma'am.
You will do imaging first. So what is the imaging of choice in this patient?
Ma'am, MRI, I mean, contrast enhanced MRI with MRI of oral cavity and neck will be performed, ma'am.
Why do you want to do an MRI?
Ma'am, for better soft tissue, better soft tissue invasion will be assessed, and depth of invasion and neurovascular invasion will be assessed in MRI, ma'am.
When will you do a CT scan in oral cavity lesions? Listen to my question properly. Oral cavity, when will you do a CT scan and what technique?
Ma'am, in oral cavity, the CT scan is performed in case of buccal mucosa lesion with puffed cheek technique, ma'am.
Why puffed cheek technique?
The puffed cheek technique will differentiate. I mean, will help for the buccal mucosa lesion to be clearly visible, ma'am. So puffed cheek technique will be performed
So it will separate the mucosa, that is your buccal mucosa, from the adjacent structures, essentially from the bone, the alveolus. All right.
Yes,
so you
ma'am.
will see the lesion much better. All right.
Yes.
So you've done an MRI. The MRI tells you what all information will you get on the MRI?
Tumor extent and dimensions of lesions and perineural invasion and depth of invasion and any muscle infiltrations are present and any marrow infiltrations will be assessed in MRI, ma'am.
Why are you talking about marrow infiltration in this patient? Is it so important in the tongue in the kind of lesion that you've shown, or is it important in buccal mucosa where you want to see, or an alveolar lesion?
It's not significant in tongue for this patient, ma'am.
For this, see, when you're doing your practicals, you have the patient sitting in front of you. So you have to talk regarding this patient, and then seeing the patient's, the examiner's expressions or what the examiner wants, you can modify your answer to give a more generic answer or a more theoretical answer. But it is important that you talk about the patient who is sitting in front of you and whose examination findings you have presented. All right?
Yes, ma'am.
That is very important. Then you're not talking theory. In your theory paper, you can write all the options and all the various advantages and disadvantages. But if the patient is sitting in front of you, like in a practical exam, you should answer pertaining to that patient who is sitting in front of you. All right. So
Sure,
now
ma'am.
you've talked about this lesion. So you found out that this lesion is restricted. And what else will this MRI tell you? You've given features of the primary disease. What about the neck?
Yes, ma'am. As well as extranodal extension will also be nodal involvement, and extranodal extension of cervical lymph nodes will also be assessed in MRI, ma'am.
So which is the better tool to assess for the cervical lymph nodes? MRI, CT scan, ultrasound, or PET CT? Which is a better tool in a patient who has this node? For the sake of time, I'll just tell you that it's an ultrasound with an ultrasound guided FNAC is good if you have a clinically N0 neck or a clinically CN1. But the point is CT and MRI are okay for the neck provided you have gross lymphadenopathy, which is malignant. Otherwise, an ultrasound with an ultrasound guided FNAC is the tool of choice. Now tell me, when will you do PET CT in a carcinoma tongue?
If it is a T3, T4 disease or any bulky nodal involvement or multiple lymph nodes involvement, PET CT can be performed, ma'am.
So you will do it for anything with a bulky T3 or T4. And I see answers about advanced disease. What is meant by advanced disease? And somebody has gone to the other end and has said never. So actually, it's a combination of all the answers in the chat box. So when you have T4 disease, you have multiple bulky lymph nodes and lymph nodes in the lower neck. And of course, the other reasons are recurrent disease and in disease in which you may think that you want to know whether you should go ahead with extensive morbid surgery. In such patients, you may want to do a PET CT to ascertain the extent of disease and decide whether you need to do you need to proceed with the management plan of management that you have decided. So now coming to the management, is there anything else, any of the other examiners or anybody else in the group would like to ask anything or say something or make any comment?
So any faculty or someone who asked some questions can ask. They unmute themselves.
Madam Tanveer here.
Yeah, Tanveer, please go ahead.
Yeah, Madam, only one thing, like many a times, resident, I mean, they loosely understand PNI and PNS. So they have to understand that when they say PNI in MRI, PNI is basically a pathological finding, and if something which is seen radiologically, then that has to be termed as a PNS. So perineural spread and perineural invasion. So it is very loosely it is used. So that has to be kept in mind.
That's correct what Dr. Tanveer is saying. Please note that. Somebody has also made a comment about pan endoscopy. Why do you want to do a pan endoscopy in a patient with this kind of a lesion on the right lateral border of the tongue? And somebody has written triple endoscopy. Why do you want to do it in this kind of a patient? Are you suspecting a second primary? Or are you suspecting that this patient has field cancer? So in what proportion of patients do you get field cancerization and you have the need to do a triple endoscopy or a pan endoscopy? I wouldn't suggest it for a patient like this with this kind of a lesion and this stage of disease.
So, not nasopharyngoscopy, but people go for the DL scope in upper GI and
DL scope is okay, but not upper GI scopy. Why are you? Do you have symptoms?
No.
Do you have any kind of history, or is there any finding that you see on the imaging? Then you would go for the triple endoscopy without the nasopharyngoscopy.
Yes, ma'am. Yes, ma'am.
Yeah. Okay.
Yes.
Madam, can you also just enumerate for the sake of resident that when is the examination under anesthesia? That is also something which is mandatory but logistically not being done. So which patient should ideally undergo examination under anesthesia?
Patients who actually have borderline resectable lesions or in whom the third dimension cannot be assessed properly on your routine evaluation, which includes both your examination as well as your imaging. And it is important for you to ascertain the kind of surgery or the nature of the treatment that you want to give these patients. Then the patient should definitely undergo an examination under anesthesia, because it helps you in ascertaining the third dimension as well as the exact extent of the local disease. The other thing that somebody has written very correctly in the chat box is that the patient has severe trismus, which again means that you've not been able to assess the patient properly. In those patients, you may want to do an examination under anesthesia. Nowadays, what many surgeons do is actually a fiber optic laryngoscopy or an examination with the scope being passed through the nose into the oral cavity, because you have to understand that when you do a DL scopy, at that time the lesion may actually be seen only because a DL scopy is actually a rigid scopy, so it may not give you evaluation and information in all three dimensions. So it is important for you to know that also. Yeah. Next, anything else that anybody else wants to say? What's this? Okay, anything else that anybody else wants to say? Then should we go ahead? So, okay, you've done imaging, you've ascertained the depth of invasion, your change, okay, M0 or MX. Actually, AJCC, after you've done imaging, it tells you whether you should do, whether you can call it M0 or MX, but clinically also, if you've evaluated the patient in all three dimensions, so that supposing this was a narrower lesion, flatter lesion, not too much depth, then you could perhaps call this an M0 also, and not necessary to call it an MX. All right, that is what the AJCC tells you. Okay. So that's one thing. The next, so now you have done imaging, you've done your biopsy, you've done your other evaluations that are essential, like your CBC, your biochemistry. And what else will you do? Any other ancillary investigations that you would want to do for this patient?
A metastatic workup.
So what will you do in metastatic workup?
As it is a T2N1 disease, I will perform contra-CT thorax or ultrasound abdomen to rule out the metastasis, ma'am.
Would you do an ultrasound abdomen routinely? Actually, the yield of ultrasound abdomen is so low that you really do not do ultrasound abdomen or any imaging for the abdomen. You could do an NCCT thorax, or in some places where that may be very expensive, you can also do a chest X-ray for this stage of disease. All right?
Okay, ma'am.
But the other reason why you may want to do it, somebody has very correctly written, the chest X-ray as well as you would want to image the thorax, simply because this patient is a smoker and a high-risk patient. All right. Now, the thing is, yes, somebody has written correctly that they would also want to do nutrition, speech, and hearing. Why hearing assessment? Wait, we're coming to management. Wait. Okay. So now this patient, I know I'm going to stir up a lot of controversy. This patient now, after all your investigations and about all your management, you have established the nature. This patient is a CT2N1M0, that is a stage 3 cancer. So now what are you going to call this patient? How are you going to manage this patient? Shalini.
Yes, ma'am. So after the nutritional assessment and the speech and swallowing assessment, and I will plan for, after a multidisciplinary discussion, patient, I would request for I will plan for a partial glossectomy with modified radical neck dissection, ma'am, followed by, based on the histopathological finding, we'll proceed on with the adjuvant treatment, ma'am.
So you said that you would do a partial glossectomy. Nowadays, please remember that nobody calls it a partial glossectomy. Either you stage the glossectomy by the different types of glossectomies that are performed, or you call it a wide local excision of the tongue lesion with, you're saying, a neck dissection. Now,
Yes,
neck dissection, do you need to do a modified radical neck dissection in this patient?
As it is a N1 disease, can perform
So then
selective neck dissection also, ma'am.
selective neck dissection, mentioning the levels that you've dissected. So what levels do you dissect?
So level 1 to level 4, ma'am. A selective neck
Level
dissection.
1, which level 1 will you do?
Level 1B and 2, 3, and 4, ma'am.
You would do 4 also in this patient?
Yes, ma'am. As it is a node positive disease, I will perform level 4 also, ma'am.
So somebody has said it is tongue. So then because of the expectation of skip metastasis, you may want to do a level 4 also. But the usual rule is that if you do not have metastasis to level 2B, you usually do not have metastasis to level 4. But I would also accept the thing that since it is a tongue with N1, I may want to clear out the level 4 also. Now, where is the evidence that you have to do a neck dissection in these patients? Supposing this was N0 then? If this was N0, then what would you do?
If it is an N0 disease, suprahomohyoid neck dissection can be performed with 1 to 3.
Will be performed or can be performed?
It should be performed with a level 1 to level 3 nodes will be dissected in suprahomohyoid.
Why do you say so? Where is the evidence?
Ma'am, in the elective neck dissection in clinically N0 disease, occult nodal metastasis can be 20 to 40% risk of occult metastasis will be present, ma'am. So
where is the evidence? Talk about the evidence in the chat box. So many people are writing the evidence.
D-Cruz trial.
The N0 trial by Dr. Anil De Cruz.
Yes, ma'am.
Right?
Yes, ma'am.
So what does he say? After what depth is it more important?
Ma'am, it improves overall survival and
3 millimeter. Then the incidence of lymph node metastasis even in an uninvolved neck becomes very high. So that is why it is important to do a neck dissection in these patients. All right?
Yes, ma'am.
Okay. Kanu, help me, man. Think of more questions to ask these people.
Madam, you can ask radiation details, chemo details, and toxicity also.
Kanu is also not leaving me. Tanveer, I've seen Shuporna Di also. Please ask questions.
Dr. Tanveer, are you there?
Is Dr. Senapati there? Even he should ask questions, no?
Sir. I think sorry, not.
Okay. Shuporna Di as well as Tanveer, please ask questions. So now some people have said tongue, you do surgery, wide local excision and neck dissection. But some people have said CRT. Why CRT? And how CRT? And if you have to say yes CRT versus no CRT, then can you answer that question, Shalini? Your examiner tells you no. I'm a radiation oncologist. I definitely have to give RT to this patient. I will use non-surgical methods for this patient. Can you substantiate that claim? Can you say that this is how it should be done versus no, this is not done?
As it is a resectable. As it is a resectable.
Why do you not want to do surgery for this patient? So your friends are actually helping you. So either the patient is unfit or patient is unwilling or it is unresectable disease. So you may not do surgery in these patients. But what is the evidence that forces compels you to do surgery in these patients followed by?
Radiotherapy.
Huh? Who's Abyss at all? I don't know. Omar, can you tell us about this patient? About this evidence?
Dr. Sharbani,
Yes.
I just want to ask one question. If that ulcer has extended up to the tip of the tongue, what will be the extent of neck dissection?
So usually the surgeons would still want to do an ipsilateral neck dissection because it is N1 and if imaging shows no significant lymphadenopathy on the opposite side. But at the same time, some surgeons would also do an elective neck dissection of the opposite side because it would serve two purposes. One is treatment and the other one is prognostication. But when your surgeon has done bilateral neck dissection, you anticipate greater morbidity with adjuvant radiotherapy. So that's the thing that you have to keep in mind. But when it's coming to the tip of the tongue, or if it crosses the midline, then you should be doing contralateral neck dissection as well as addressing level 1A.
The question was for students.
Oh, okay, sorry. I thought
No problem.
that's what I was wondering. Okay. What is this elective versus therapeutic neck dissection? What is the difference in the meaning of the two terminologies? Somebody is asking this question. The answer lies in the terms itself that have been used. Now, supposing this patient, you would have to correct. So that's the same thing that goes, yeah, that's correct. So elective essentially is when you have an N0 status. You're doing it when there is no disease, whereas therapeutic is when there is disease and you're addressing the nodes that are involved as well as the levels that are involved. Okay, now somebody asked about, now tell me, supposing you had to treat this patient with non-surgical methods, what are the options that are available to you?
Radiation therapy with concurrent chemoradiation therapy will be the option, ma'am.
Why concurrent chemotherapy?
If a patient is if patient is refusing surgery and it is in unresectable tumor, will perform concurrent chemoradiation will be better than going with definitive RT.
This is stage 3 disease. So obviously you're going to give combined modality management. And if you're doing non-surgical treatment, you will give concurrent CTRT.
Yes, ma'am.
Now, why will you not practice brachytherapy alone in this patient?
As it is a node positive disease.
Okay. Now, what are the indications for adjuvant therapy after surgery in this patient?
Ma'am, adjuvant RT, if it is T3, T4 disease or node positive, LVSA and PNA positive and close margins, adjuvant RT will be performed, ma'am. And if ENE and margin positivity is present, and adjuvant CCRT will be performed.
Please listen to me. Answer the question as factors related to the primary disease, factors related to the nodal disease. So factors related to the primary disease are T3, T4 disease, LVSI, PNA.
Yes,
and margin status. All right?
Yes, ma'am.
Then nodes, multiple level nodes, node with ENE. Correct?
Yes, ma'am.
So then in PT2, PN1, PT2, PN1, will you give adjuvant radiotherapy or no adjuvant radiotherapy? PT2, PN1.
Yes, ma'am. Adjuvant radiation therapy will be given.
Yes, now, what are the indications for adjuvant CTRT?
Externodal extension positive and margin positivity is an indication.
What is adequate margin?
0.5 centimeters, ma'am.
What is close margin?
It's less than 5 mm will be the close margin, ma'am.
What is it for HPV positive cancers?
1 centimeters, ma'am.
Supposing you had an oropharyngeal lesion with X mm margin, when would you consider this margin close or positive? Actually, Diksha, no. Now, if you look at the Pathos trial as well as the ECOG 3311, the extent of the intermediate group and the intermediate group, the indications for adjuvant RT are very different, and they are different by nature of the extent of ENE and the positive margin and the margin status. All right. So actually, there is a difference between the HPV positive oropharynx and the other head and neck cancers. All right. Also, if you look at the salivary gland and the larynx, their positive margins would be a little different, and we will discuss that afterwards whenever later. Okay, so this is what you all have to remember. Now, what is the dose of adjuvant radiotherapy that you would want to give?
Ma'am, it will be 60 gray in the 60 to 66 gray for a high risk volume, ma'am, and for low intermediate risk, I will give 50 to 54 gray, ma'am.
How can you club low and intermediate risk together? What is intermediate risk?
Ma'am, low intermediate risk will be the contralateral neck will be the low risk, ma'am, and remaining primary and along with the ipsilateral neck will be a high risk.
You have only level 2 that is involved even on histopathology. Despite that, you will treat the whole neck on the left side, on the right side to 66 gray, 70 gray. Will you consider that entire area as high risk? No, that is no longer done. Okay.
No, ma'am.
So what is involved and what is the involved nodal level and the involved area of the tumor, primary tumor? Those are high risk levels. The rest of the levels are low risk. Please remember that. Okay.
Yes, ma'am.
They are not high risk.
Yes, ma'am.
And I would request all of you, since you are exam going, to also read the post-op radiotherapy guidelines. All right. Now, somebody very importantly mentioned one particular trial which kind of affirms that you have to give adjuvant radiotherapy versus neoadjuvant radiotherapy. That is the RTOG 7303. That is also an important study that all of you should remember.
Yes,
and in this context, I would request all of you to know the Anang study. Actually, the studies that help you determine the total dose that you have to give post-adjuvant post-surgery for adjuvant radiotherapy, depending upon the risk status, are papers by Lester Peters, by Kianang, by Langendick, and the last one that was, it is an update of Lester Peters' work by David Rosenthal. And of course, pre-op versus post-op RT, you can look up the RTOG 7303. And of course, for adjuvant CTRT, you look up the URTC and the RTOG studies. All right. Now coming to concurrent CTRT in these patients. Somebody asked the question, why not neoadjuvant chemotherapy? Why neoadjuvant chemotherapy would be my question. I would put it the other way. Why neoadjuvant chemotherapy in this stage? There is no role of neoadjuvant chemotherapy in this patient. Neoadjuvant Mpro, very good. Who said neoadjuvant Mpro? So what is the study that talks about neoadjuvant Mpro? And in this patient, would you really advise a patient to undergo a neoadjuvant Mpro? Keynote is not enough. You have to, keynote 6, 8, 9 is what you have to talk about. And will you offer 6, 8, 9 in the patient like this?
No, ma'am. No, ma'am.
What kind of patient would you offer 6, 8, 9 to? What is 2312? 2312, I don't know what this is. Anyway. So what would you do for CTRT in this patient, and what is the modality of CTRT that you do in this patient?
Concurrent chemoradiation with weekly cisplatin of 40 mg per meter square will be.
So do you know the evidence for weekly cisplatinum? Where do you have evidence for weekly cisplatinum?
No. 3 weekly of 100 mg, 3 weekly cisplatin.
You're not wrong if you say weekly. Where is the evidence from? No, if somebody says TMH study, no, definitely not. Because if you look at the weekly versus 3 weekly, in the cisplatinum study, it is negative. You have to quote the Jacob study, that is a Japanese study for weekly versus 3 weekly. All right?
Okay, ma'am.
Otherwise, the evidence is for 3 weekly.
Okay, ma'am.
Okay? Yeah.
Yes, ma'am.
Now, if the patient is not suitable for for cisplatinum, then what are the other agents that are available?
Cetuximab can be given, ma'am, if patient is not fit for cisplatin based on Bonner et al, ma'am.
What was the major population in Bonner study?
A major population is stage 3, stage 4, oropharyngeal and oropharynx and hypopharynx.
Definitive targeted therapy plus RT, right?
Yes, ma'am.
Most of the population is not adjuvant.
Yes, ma'am.
You can extrapolate from adjuvant there to here, but it is Bonner, but you have to also know what the major population in the Bonner study was. All right?
Yes, ma'am.
Okay. So then you give CTRT. Now, what kind of radiotherapy technique will you utilize in for definitive CTRT if you were giving definitive CTRT in this patient?
IGRT technique will be performed.
IGRT with IMRT with IGRT. Don't say IGRT first.
Yes, ma'am. Yes, ma'am. IMRT with IGRT. Yes, ma'am.
Will anybody use 2D? Don't say no. You can do good 2D RT with cobalt also with. No, 1 minute. What was the previous one? Somebody wrote something very interesting. Wait a minute. Where no LINAC is available. Correct. So, Pooja, you can do, but what is the thing that you would ensure that this patient receives the right kind of radiotherapy with the right kind of dose? You have to make individualized tissue compensators so that you can deliver 70 gray. Yeah. And you have to do reduced fields at the right time and give good radiotherapy at the right time. Ask Dr. Kanu and Dr. Tanveer about it. They will tell you you should. Why bolus? Why do you need bolus? Bolus for what? Somebody has written bolus and phases. Phases is all right, but bolus for what? You don't require a bolus in this case. All right? You need to use tissue compensators which are made individually for the patient. What else can we use as a tissue compensator in this patient if you can't make tissue compensators?
Wedges.
Very good. So you have to use the appropriate angle of wedges, not a 15-degree wedge. Huh? That would not be adequate for this patient. Okay. Now what else? Kanu, what more to ask, man? Okay, what are your volumes of radiotherapy? Tell me that. I corrected somebody, but then at the same time, so you have your involved field. That means whatever is your involved disease plus your involved level of lymph node, you will give it the highest dose, and the remaining levels you can give it the low risk dose. Now tell me something, is there a room for reducing the volumes of radiotherapy that you do?
No, ma'am.
There is.
Okay.
Volumes of radiotherapy, you can treat less of the neck if you want to. There is data that is coming up. Plus you have data that is coming up. So you have data from, so you have Kierke's data that has been published. But of course, it is not important for you to know that. But yes, you can also hypofractionate these patients. That is another thing that you should know about from the HYPOT study that is from the Indian continent itself. Any other questions, Tanveer or Kanu? Adaptive radiotherapy, somebody is asking this question again and again, but I would just say adaptive is a function of whether you see any flap shrinkage, weight loss, or if you're giving definitive CTRT, if there is any change in the contour of the patient. Now, this adaptive will essentially be, somebody writes after 20 gray, there is no hard and fast rule, okay? Most of the adaptive radiotherapy, if it has been done in the 4th week of radiotherapy. And in the 4th week of radiotherapy, and both the trials of adaptive radiotherapy that have been published are negative. So you have to do adaptive because adaptive is something that is ingrained and intuitive. That means if you see a patient who has lost a lot of weight or there is a change in the body contour, you may require to do adaptive radiotherapy depending on what is the indication for adaptive radiotherapy. Now, role of altered fractionation, that was the other answer that I was looking for in patients with, see, when you do 2D RT, it is usually bilateral radiotherapy for tongue. Now, altered fractionation, let's talk a little bit about altered fractionation because we are all, because we are radiation oncologists finally. So, altered fractionation, when and how? And what is the dose that has been described for altered fractionation? What are the various schedules that have been used? Shalini, can you answer that question? या मैं ही पूछ रही हूँ, मैं ही आंसर कर रही हूँ.
Ma'am, altered fractionation can be hyperfractionation or accelerated fractionation or accelerated hyperfractionations, ma'am.
No. So what is the altered fractionation that has been described? You said hyperfractionation.
Yes,
You
ma'am.
said accelerated fractionation without a reduction in total dose. That is the way you're supposed to talk about.
Okay,
Somebody
ma'am.
is writing RTOG 9003. Now tell me, RTOG 9003 talks about which are the 4 fractionations that it talks about?
Standard conventional fractionation, hyperfractionation, and accelerated schedules, ma'am.
So accelerated schedules are which schedules? Now accelerated concomitant boost. Now what is accelerated concomitant boost? You need to know this. See, now you're a radiation oncologist. You should know about what are the accelerated thing. What is accelerated radiotherapy with concomitant boost? What is it?
Ma'am, it is Ma'am, it's accelerated concomitant boost. Is
the one that was used in RTOG 9003. So all of you need to be familiar with the March meta-analysis, which is March meta-analysis 2, because it is the latest update that is available on altered fractionation in head and neck cancers. So you need to talk about hyperfractionation. You need to talk about accelerated fractionation without a reduction in the total dose, because it is hyperfractionation which has the maximum benefit. Hyperfractionation with chemotherapy has the maximum benefit, then followed by accelerated fractionation without a reduction in the total dose like the Dahanka 6. Then you have chart. Chart is actually negative in head and neck cancers, but chart is positive for lung cancers. And you need to know what is the dose schedule of chart. In place of chart, you have the chart well, which is a Polish trial. And then you need to know what is accelerated fractionation with a concomitant boost. Now, there has been randomized evidence to say whether you do the concomitant boost in the first 2 weeks or the last 2 weeks of radiotherapy. And the last 2 weeks was found to be more advantageous than the first 2 weeks. So you need to know about all these things also as radiation oncologists. All right?
Yes, ma'am. Yes, ma'am.
Somebody is talking about Hypno. Yeah, Hypno 55 in 20, but that was used mostly for definitive radiotherapy. But you need to know what Hypod from AIMS, the main AIMS, and because that is the one that has been done in adjuvant setting. Anything else? Tanveer, Shuparna Devi, or Kanu? Anybody else?
Yes.
Any other
Any follow-up toxicities? The two lines, madam.
Toxicity. Now, what is toxicity a function of in tongue cancers?
It can be acute toxicities or late toxicities, ma'am. Acute toxicities can be mucositis,
When do you call
dermatitis.
it acute toxicity?
Ma'am,
When do you call it acute?
ma'am, acute toxicities will be less than less than 6 months durations will be acute.
6 months, 6 months, 6 months.
Sorry, ma'am. Like less than 6 weeks duration will be acute toxicities,
Less
ma'am.
than 3 months, 90 days.
Okay, ma'am.
Then you have more than 180 days is late toxicity. In between,
Yes.
what you have is chronic, acute on chronic. Okay?
Yes, ma'am.
So you need to know that 90 days, 180 days, and what are the commonly expected toxicities that you have in CA tongue treated with either adjuvant RT, adjuvant CTRT, or definitive CTRT?
Ma'am, it will be mucositis, dermatitis, and altered taste sensation or increased salivations or
Increase.
difficulty in
Don't have
swallowing.
transient xerostomia.
Yes, ma'am. Transient xerostomia also will be present, ma'am.
Somebody has written fatigue. When do you see fatigue and why do you see fatigue as a result of radiotherapy?
Poor nutrition is present, or
Which was the study that first reported fatigue in head and neck cancers? It was first reported as an entity in the passport study. When you did IMRT and the IMRT beams went through the dorsal vagal nucleus. All right. So that is the first report of fatigue in head and neck cancers treated with IMRT. Of course, there are various other reasons for fatigue, and that could be general debility, low hemoglobin, and all the things that you have written about. Now, somebody is telling me what are the volumes. Now, typically the volumes described by us are the high risk volume and the low risk volume. The high risk volume is the area that has the disease both at the primary and in the neck. And the low risk volumes are the volumes that you would give elective doses of radiotherapy to. Now the point is whether you want to do reduced volumes of radiotherapy, that is up to you, and we are doing it just now in case of a trial. And I would suggest, unless you're confident about what you're doing, it would be better in tongue cases to do bilateral. And in the lateralized buccal mucosa, you can do only lateralized radiotherapy. If you read the post-op radiotherapy in what you call contouring guidelines, they tell you when you call a patient lateralized versus when you call a lesion that is midline. So 1 to 1.5 centimeter away from the midline should be a patient to call it a lateralized lesion. So somebody has written PTV tumor. Now, I typically do not give a higher dose of radiotherapy more than 60 gray unless there is a close or a positive margin. Okay. And yes, I would like to always, whenever possible, fuse my present planning CT scan with a preoperative MRI. Okay. Now, somebody has also asked about what would you call an intermediate risk in the adjuvant setting? Nothing, because you already have the involved and the uninvolved levels, and the surgery has told you, the neck dissection has told you whether the neck is involved or not involved. All right, ma'am, here also first we will contour pre-op. We always fuse, that's what I'm trying to tell you. And percentage of lymph node involvement means what? Are you asking about the log? There is a definite relation with the log. Yes. In case of ENE positive, should we go? I don't give, but yes, the RTOG and the URTC trials have gone up to 6 gray in 33 fractions. So you can give a higher dose if the ENE is positive or if the cut margins are close or positive. Yes. Because the trial from Rosenthal, which is an update of the Lester Peter trial, shows that there is no advantage of giving more than 63.6 gray in patients, even in the presence of high risk features. So please read up that study also, which talks about whether you should escalate doses even in high-risk patients post-op, and these patients are patients who did not receive minute concurrent chemotherapy. Any role of SLNB? Wow, that's a nice question. Are you interested in head and neck cancer? Then I will tell you a little bit more about SLNB. Because SLNB throws a different angle completely into your thing. Now, what is the role of SLNB? For us as radiation oncologists, we should look at whether there are any adverse features at the primary which warrant giving adjuvant radiotherapy. And the other thing that we do not know anything about is what is the implication of having isolated tumor cells. So that is the role in SLNB. Otherwise, the role essentially is like what you would do in the N0 neck, and I think the reference there would be N0 trial. But you can look at Claire Schilling as well as the Hasegawa trial as well as the SEN trial for the SLNB role if you are interested. But essentially there it would be for any aggressive features at the primary you would want to give adjuvant therapy for, or if there are any things that you find on the adjacent node. Already removed by surgery. Okay. Stage-wise percentage, I would like you to refer to Clifford Chow's paper, which gives you both in the contralateral neck as well as in the ipsilateral neck with the different sites in the head and neck region. Okay. Yeah, Kanu, I think I have finished. If there is anything else that people want to ask or say, then I would leave it to them.
Any faculty or any student ask any questions, please. Madam is here. We are lucky and very fortunate. Madam is with us. Anyone? So shall we close, madam? Otherwise,
I'm okay. Okay, merits and demerits of parallel or force field.
please tell me. No problem.
Okay, somebody has asked that question. So what are the merits and demerits? You all tell me. So one is obviously you're treating both sides of the face and neck. If you treat both sides of the face and neck, you will get a higher incidence of xerostomia. All the late effects of radiotherapy will be perpetuated if you use by merits and demerits. But what is the merit? The biggest merit is that you will not miss disease if you plan your fields properly. But you can do this also well by using individualized tissue compensators. Okay. What was the evidence? Used the thing David Rosenthal. Okay, Rosenthal, head of Department of Radiation Oncology at the MD Anderson Cancer Center. SIB versus sequential. How do we justify surgery or RTA? See, actually, all the evidence that you have, the SEER database, then the trial from Singapore, I forget his name. That's something in mind. So from there is where they actually take out some data for definitive CTRT in head and neck cancers, in oral cavity cancers versus surgery. And what you see from all this evidence that is available, that the control rates are very poor when you do non-surgical treatments versus when you do surgical treatments. Okay, but not to say that there is a definite modality and it is feasible to give higher doses of radiotherapy. If you want to look at success that is available post giving non-surgical treatments for patients who are not the surgical candidates or who have refused surgery, if there is no node or the propensity for lymph node involvement is low, you can do radical brachytherapy. But typically in the oral cavity, except for sites like the commissure or buccal mucosa, you would always like to give a combination of brachy plus external beams simply because the incidence of lymph node involvement is very high. Otherwise, from the University of Chicago, you have regimes which are sequential regimes which have used sequential regimes and intensive regimes which have resulted in higher response rates and perhaps higher control rates. But at the same time, you have to understand that for non-surgical candidates, the survival is usually not more than 26 months or so. Okay. Now, the other thing is more case discussion with you, madam. My God. SIB versus sequential. Now, there is some data on SIB versus sequential. There is a minimal advantage of doing sequential, but the logistic reason of delivering a dose that is tumoricidal and at the same time shortening the course of radiotherapy by 1 week is what speaks for SIB as against sequential. But if you look at the evidence, it may be slightly superior, but not really that superior that it makes too much of a difference whether you do SIB or sequential. Now, depending on whether you are doing hyperfractionated radiotherapy with concurrent chemotherapy, you may want to do it sequentially because your volumes are different, and you may want to do SIB otherwise. Okay, role of mixed beam therapy. In carcinoma lip, unless it's a proliferative and a very thick growth, I usually would do a radical brachytherapy, because once I have established that the patient has no lymph nodes and also that the propensity, that the thickness of the growth or the depth of invasion is low, I may do radical brachytherapy. But if it's a thick proliferative lesion, I may want to do external beam radiotherapy, flatten out the lesion, and then do the implant. See, level 5 now, typical, if you go by Julian Biao's paper, he will say do level 5. But we find that if level 2A is not in, if 2A is involved, then only you go to 2B, you don't go to level 5. So unless 2B is involved, we usually don't go to level 5 in oral cavity lesions. I hope I've answered most of your questions. If there's anything else, I'd be happy to answer questions through Kanu. You can write to him and he can get back to me. Yeah, Kanu, is that all right?
Yes, ma'am.
Okay, then bye. Good night, all of you.
Thank you, ma'am, for your presence and insights. The students are going for the exam. Hope you will also attend as the examiner comes somebody and he will be lucky.
Anyway, I know that's a different story. Okay. Thank you. Thank you very much, and all the best to all of you. Thank you. Thank you, Kanu.
Thank you, ma'am. Thank you, Dr. Salini.
Thank you.
And you have presented nicely, and we will give the certificates after that. Okay, we have an.
Yeah, Shalini, I did not purposely respond because I wanted to reserve all my comments for afterwards. Okay.
Yeah, ma'am. Thank you, ma'am. Thank you, sir.
Bye. Bye. Good night, all of you.
Good night, ma'am.
Thank you, ma'am.
Bye. Bye. Thank you. Bye, Ajitesh. Bye, Tanveer. Bye, Shupurnadi.
Thank you.
Bye, ma'am.
Thank you.
So we have Dr. Piyush. Are you there? Dr. Piyush? Hello? Dr. Piyush? So we have a second there. Why is not listening? Oh, hello, Dr. Piyush.
Hello, am I audible, sir?
Yes.
Sir,
So,
actually, my connection got lost.
Second program is OSCE radiology by today. So I will. There are few radiology slides. You will get questions in the spottings or during the OSCE programs. And we have Dr. Piyush Mishra, SCG Kotak. We will show the pictures, images, and we will associated questions we will ask, and that people will understand what is going to be asked in the various radiological programs. So, Dr. Piyush, are you there?
Yes, sir. Yes, sir. I'm there, sir.
So I will ask one the radiology slide, and I will associate questions. I will ask. Okay.
Sure.
So this is the question number 1. Identify the images and what is the probable diagnosis, and how in which way you define the X-ray.
So this is the X-ray of the skull, showing the multiple sizes, lytic lesions of various sizes in the skull, probably the raindrop appearance. And by seeing this peculiar feature, I think the most probable diagnosis is the multiple myeloma.
You can see the mandible also. Australated lens, you can see the mandible also. Okay.
Yes, sir. Yes, sir. Yes, sir. There.
Do you know CRAB criteria?
Yes, sir. It is basically related for the lab parameters for the multiple myeloma. We have the hypercalcemia, renal insufficiency, that is along with the anemia and the pathological bony lesions. So,
Okay. Do you know slim crab?
yes, the SLIM is another updated criteria for that. So it is basically for the S chains, light chains of particularly for the IgM antibodies. Sir.
Okay. So the slim full form, you know? Okay. So this is a multiple punched out
Sir, am I
lesions.
audible? Yes, sir. Yes, sir. Yes, sir. Yes, sir. Hello.
Slim
Yes, sir.
crab.
So
Slim
slim
crab.
criteria means basically for yes, sir. The clonal self percentage, that is of the 60 percentage. I is for the Li is for the light chain globulin ratio, and M is for the that is the light chain of globulin M, IgM particularly, and M is for the MRI with more than one focal lesions on the MRI. Sir.
Thank you. Question number 2. This is a image. Identify the sequence and identify the lesion.
Yes, sir. So this is the axial section of the to the brain, showing with the T1 weighted MRI, showing the features extra-axial lesion with the some heterogeneously enhancing, and the dura mater is slightly thickened. So probably this is the sign of the dural tail sign seen in the your meningioma. Sir.
Meningioma. Any other signs you know meningioma? So there are 5 to 6 signs.
No,
so one is the dural tail sign. Another is the hyperostosis. Another is the sunburst appearance. Ginkgo leaf sign in the spinal meningiomas. There are many signs are there. Funny signs are there. You can go later and find out in your book. And can you classify the meningiomas?
Sir, can you please repeat the meningioma?
Can you classify your grades of the meningioma?
Yes, sir. Basically, meningioma can be, according to the WHO, can be in between the three classifications per se. So they are basically broadly they are classified into the three subtypes: grade 1, grade 2, and grade 3. The grade 1 being the most common type. Only, sir, I've remembered a few names like the angiomatous and fibroblastic are in stage 1. Sorry, the grade 1, and in the grade 2 there are atypical or the choroidal cells are there, and in the grade 3 they are having the much higher risky features. Yes,
but
the malignant.
the classification is slightly different in the molecular based in the 2021 WHO criteria. Okay, what is Simpson's grading? You know, Simpson's grading.
Yes, sir. Yes, sir. Basically, they are divided into the but resectability criteria based on the resection of the grades. So they have basically 5 Simpson grades, sir. The grade 1 is the one where there's a macroscopically complete tumor resection has been there, and fifth is there's the decompression with or without biopsy. Then the in between 2, 3, and 4 they ranges from that, sir.
Okay, so Simpson grade is mainly for the surgical evaluation, surgical how much they did surgery based on the Simpson grading. Still, the Simpson grading given at the 1960 era, still it is holds good in now these days also. Can you identify the section and what is the theme? Number 3 image?
Yes, sir. Sir, these are the this is the again the sagittal section of the uh, uh, body showing the latex lesions.
Sagittal section of the dorsal lumbar spine.
Dorsal lumbar spine, sir. there can be seen as the lytic lesions involving the D8 and the D12, and particularly the L1 compression lesion can be appreciated, sir. Probably the lytic vertebral mets.
Yeah. So this is how to count the vertebra. So this is the S1, L5, L4, L3, L2, L1. This D12 is the collapsed. Okay. So this is a D11, D10, D9, D8, D8 and D7. Okay. So how to sorry, Prasad. So
Hello. Yes, sir.
yes. So how will you score? It is needs radiation or surgery. How will you score it? Hello.
Yes, sir. We have the criteria known as the SINS criteria of the SINS score for that, sir.
Can you full form define the SIN score?
Yes, sir. It's basically based on the severity of the lesion,
No,
irritability feature, the nature.
Full form of the SIN score.
Sir, yes, sir. The severity. I is for irritability of the lesion. N is for the nature of the disease, and S is the stage particularly. And again, the third S is for the final stability.
So in this case, what you will do? Whether we will go for surgery first, fixation first, or radiation first?
Sir, if the patient will present with the upfront very presenting with a vague pain, then we shall proceed for the uh, uh,
So it is a
palliative
totally
radi.
collapsed vertebra.
Yes, sir.
First, you have to go for stabilization. So you calculate with the SIN score. Then go for the stabilization of the process, but you have to count what is the survivability and life expectancy. Accordingly, you have to manage. Okay. In which primaries you will find this will this malignancies will metastasis like this?
Sir, if mostly these are the lytic lesions, so the malignancy which have the propensity for the lysis, bony lysis, are gonna be there. Like the breast can have the both lytic and blastic, so breast is there. Then other one the lung, multiple myeloma, and followed by thyroid, sir.
Just honors level question. Can you tell me what is the minimum SIN score and maximum SIN score? So minimum SIN score is 0 to 0 and maximum SIN score is 18. So 13 to 18 is definitely surgery is recommended. Okay.
Yes, sir.
Okay. Identify the image and probable diagnosis.
So this is the MRI of the head region, showing the hyper intense lesion in the right lateral part of the tongue, and since the medial lingual septum is crossed, so it is crossing the midline, sir. So I think this is the case of carcinoma right lateral border tongue.
Which image this is? What is the image? This is CT or MR?
Sir, MRI.
MRI. So posterior 1/3 tongue is involved or not?
So the lesion is in the right lateral third, involving the posterior lateral part is involved, sir.
Okay. What are the so some patient undergone surgery? In which cases you will go for the radiation?
Sir, in the for the post-operative radiation therapy, if the tumor is in the T stage of the tumor is in the range of 3 to 4, and particularly the margins are closed, and there are lymph nodes are there, and adverse pathological features as per the NCCN like LV and LVSI, PNI, or the bone is involved. And sir, also the if the DOI, particularly in case of tongue, the DOI is more than 4 mm, then we should consider for the post-op RT, sir.
Okay. Any conditions you will go for the chemoradiation for this?
Sir, yes, sir. If the margins and extracapsular extension are positive, so then we shall consider for the concurrent chemotherapy. These are the hard risk factors. Whereas there are other soft risk factors based on the famous Bernier and Cooper trial. Particularly if the stage 3 or 4, if the level 4 or level 5 lymph nodes are involved, along with the PNI and LVI positivity. And if more than 2 lymph nodes are also involved, then we shall consider for the concurrent chemotherapy, sir.
So identify the image.
Yes, sir. So this is the chest X-ray PA view showing the lung field. We can see the trachea is in the midline, and particularly there is some pathology noticed in the bilateral lung field. So it's probably the metastasis, sir. Probably the cannonball met, we can say.
Where you can get mostly?
This is most commonly get from the choriocarcinoma. Head and neck cancer can also get to the lung. And the RCCs can also be there.
You have to tell common things first.
Okay, sir.
Renal cell or choriocarcinoma, osteosarcoma, the testicular germ cell tumors, they are very common. Head and neck malignancy you should not tell on the kind of head and neck does not more spread like this actually.
Okay, sir. Thank you, sir.
This is a identify the image. Which type of image it is this?
This is the whole. This is a snapshot taken from the whole body PET-CT image showing the normal physiological uptake in the brain, the bladder, and some parts of the intestine. Whereas there is a abnormally pathological uptake also seen.
Bladder is a
Noted in-
normal because of contrast. It is like that. Okay.
Yes, sir. It is the physiological uptake, sir. And so coming to the pathological uptake, sir, there is in the bilateral, but more common on the more seen on the right side of the cervical lymph node, sir.
So I suppose I will tell is a lymphoma. In the context of lymphoma, what is the DOLE score? What is the score? What is mean by DOLE score? You know?
Yes, sir. So DOL score is basically a prognostication score for the lymphoma, both for the Hodgkin's and non-Hodgkin. They are characterized from the 1 to 5, whereas 1 is that there's a no uptake seen above the physiological background of the scan. The 5th one is the one where the new lesion or the scan, the uptake is much higher than the liver. Coming to the 2, 3, and 4, 2, 1 is the one where
So when you consider some extra treatment of good response and bad response, so 1 to 3 are in most clinical trials, and score 4, 5 is considered as a poor response. You need further treatment. Okay.
Yes, sir.
So this is a just to identify the image and what is the findings in the image.
So this is again the axial section of the CT scan seen at the body of the hyoid, particularly at the level of C4 vertebra. There is a left-sided neck nodal mark can be appreciated on the left side, sir.
Okay. So what are the 3 clinical signs in extranodal extension? 3 pathological signs and 3 MRI signs.
Sir, yes, sir. Sir, first one is that the loss of fatty hilum will be there, and
extranodal extension.
Yes, sir, external extension, sir.
In clinical, where you
Yes,
how can you define that it is a
clinical, sir. Sir, if the lesion is involving the underlying structures also, sir, like the muscles or the skin have been involved, then it should be further then ECE positivity, or for the nodes are conglomerated in the group. Matted lymph nodes, sir. Then again, one is if the links are fixed to the surrounding structure, sir. They are called.
So okay, any MRI signs? Anyone? What are the MRI 3 signs? Some extranodal extension.
So there is a loss of fatty hilum. There will be the indistinct.
Extranodal extension. I'm asking. So this is called Segi sign, flare sign, and there are 3 signs in the MRI. So I have I have no pictures are there. So Segi sign, flare sign, and another is okay. I'm also not even. You can go ahead and find out. Okay.
Okay.
So this is just go with the question number 8.
Yes, sir. So this is the CT scan axial view showing the bladder, rectum, and only the mass arising from the lower body of the uterus, probably the case of the carcinoma cervix with the parametrial extension, sir.
So
And since this is the parametrial extension, so according to the FIGO 2018, it will be characterized to be as the FIGO stage 2B.
So can you define how in MRI how to define that this parameter positivity in MRI? So in MRI, this is called a breaching of the black ring. Okay. So if there is if this is a cervix lesion, this is the cervix wall. If there is a breaching of the black sign, this is called parametrium positive. Remember, it is a lifelong learning, and you can see in the left side of the MRI, there is a black ring is intact. Here in interrupted image, you can see there is a loss of black ring and loss of head plane. Okay.
Yes.
So identify the structure painted.
Sir, this is the structure. Probably this is the sir in the medial temporal lobe. So it should be, sir, the hippocampus. Sir, it is located in the medial temporal lobe. And the primary function is the consolidation, that is the potentiation of or conversion of short-term memory to the long-term memory, sir. And the dose constraints are for that the maximum dose should be less than 16 gray, whereas the mean dose shall be less than 8 to 10 gray, sir.
Okay. So so these are the who has done many studies in the hippocampal sparing pulmonarity, you know, Dr. Binoy Gondi. Okay.
Okay.
Okay. So find out this type of lesion.
So this is the hyperintense lesion, particularly seen in the posterior skull base, posterior part of the brain, posterior fossa, sir. So it should be the case of medulloblastoma.
What are the 3 differential diagnoses of medulloblastoma in pediatric population? So 3 differential diagnoses are pilocytic astro. It is not a pilocytic astro, looks like, and another is the posterior fossa eponyma. Okay.
Okay.
Okay. So identify this image and what is the things you are finding here?
So this is again the axial CT scan of the body showing the lung fields. Particularly, this is the spinoscapula, so this must be the D4 at the D4 level, and there is an heterogeneously enhancing lesion seen on the right side of the anterior lung field, sir.
Okay.
So
right anterior wrong, right anterior, right upper lobe.
Right upper lobe, sir. Yes, sir. D4, sir.
Okay. So this is called a wedge type sign. And another thing, what are the characteristic of a lung lesion? Speculated margins.
The speculated margin, and sir, it should be peripherally located and seen in multiple slices, sir.
Central located also, peripheral located. Okay, central located. What are the central located masses? Which type of histology you will find in the central tumors and peripheral tumors? Which histology can you guess?
The small cell is the one which is the located periphery, sir. Central, sir.
Central. And squamous?
So there will be later like that, non small cell.
Squamous is central. Adeno is the peripheral because
Adeno peripheral, sir. Yes, sir.
lining is the adeno, and tracheobronchial tree is lined with squamous epithelium. Okay.
Yes, sir.
find out the typical bony lesion.
So these is the typical bony lesion of resembling to be at the soap bubble. So this is the showing the lower end of the right leg. So probably the case of osteoclastoma, sir.
Osteoclast. So okay. So what is the other surgery? You know.
Sir, we go for the curettage and adjuvant polymethyl methacrylate cementing. And since it's also the lytic lesion with the painful mat, we generally prescribe the denosumab, sir.
Okay, radiotherapy is rarely used in inoperable cases. Okay, so bubble appearance, giant cell tumor or osteoclastoma. You remember this for lifelong. Okay.
Okay, sir.
This is what you can identify.
Yes, sir. These are the specific peaks seen in the MRS or the magnetic resonance spectroscopy. The upper image is pointing from the left side of the normal brain parenchyma, whereas the lower image is pointing to be as the hazy heterogeneous component seen in that T2-weighted MRI, probably the case of glioblastoma, sir. As the choline and creatinine, the
So
ratio
it
choline and
MRS picture. MRS is the chemical nature of the brain lesion. So mostly choline peak is raised, creatinine is down, and neuronal activity would go in the NNH is depressed. So mostly going the for the high grade glioma. Okay.
okay.
Identify the picture. What are the two views?
There are the pictures showing the two classical signs of the mammographic views, screening mammographic views. Sir. The one shown on the left side is since the axillary folds are also being visualized. So this is the sign. This is the window of MLO. That is the mediolateral oblique view. Whereas on the right side, most of the chest wall area are better appreciated. So this is the view of CC or the craniocaudal view, sir.
So whenever the examiner asks, you have to take a request for the magnifying glass to see the microcalcifications. Okay.
Oh, thank you, sir.
Characteristic is the microcalcification. So anybody can define the BIRADS?
BIRADS are the radiological criteria to define for the scene which are seen on the radiological film, particularly the mammography, to be defined as the uh, benign or malignant. So its full form is the benign breast imaging reporting and data system. It ranges from 0 to 6, sir. The 0 is the basically it is the incomplete evaluation has been done.
So who has defined the BIRAD system? You know, American College of Radiologists. Okay.
Yes, sir.
Okay. So I'm not going in the detail. People, you students, please go through it and once. Okay. So this is.
This is again the scan showing the bone scan, particularly focused on the bone. So the bone scan with the most commonly used radio tracer being the technetium 99 metastable state of MDP, sir, methylene diphosphoronate.
What is the unit? 20 millicurie.
Millicurie, sir.
Okay. So
Yes,
okay. What is any idea? What is the super scan? So super scan is usually the contrast they secrete through kidney. You can see here in the first picture there is a kidney, but in the this right side two picture the kidney has hardly ill defined because when there is nothing to excrete through kidney because extensive bone mats it goes to the whole part of the body. Okay.
Okay.
Okay. So what are the common benign lesions? Will get confused.
Since this MDP bind to the area of the osteoblastic activity is higher, so these can be raised in the cases of the fracture or benign cases like the arthritis or infectious causes like osteomyelitis, sir.
Okay. Find out this lesion and what is the technique?
This is the CT scan of the coronal section of the face, showing in the puffed cheek technique, sir. Here we can see there's a soft tissue mass arising from the right-sided upper or the maxillar alveolus, sir.
Okay. So this is called Popovich technique, and this is a maxillary, not maxillary lesion. It is a right upper alveolar lesion. Okay.
Maxillary alveolus, yes, sir.
So this is the two processes. What is the two processes? B, C, and D. Define A, B, C, D.
Sir, A is the medial pterygoid plate, sir. B is also the lateral pterygoid plate. D is clivus, and sir, C is the torus tuberous, sir.
Okay, the red arrow.
The red arrow is the medial to the torus tuberous, so probably more it should be the fossa of Rosenmuller, sir.
Okay. So this is the you find out the image and define the image and tell me the ABC.
Yes, sir. This is the MRI region showing the prosthetical features. The A part is for the transition zone. The B is the peripherally located peripheral zone, and the C1, the neurovascular bundle, which are posterolateral to the prostate. So C must be the neurovascular bundle, sir. And sir, in D, there's a much little downward side. So these may be the seminal vesicles.
Okay. So this is a peripheral zone, this is a transitional zone, neurovascular bundle, and a seminal vesicle. Anybody can define the multi-parametric MRI? What are the in multi-parametric MRI? What are the things we have to do? T1, T2, DWI,
And ATC, sir.
okay. Understood. So these things you have to diffusion and dynamic contrasted MRI. Okay, enhancement MRI. Okay. So this remember what are the MRI sequences to be done in the
Multi-parametric MRI.
multi-parametric MRI. Okay.
Yes, sir.
Identify this image.
So these are the these scan look particularly focusing on the thyroid region. We can also appreciate the terminal nodes. So this may be the thyroid scintigraphy
Thyroid
or
scintigraphy.
the iodine cancer.
What is the indication? Benign and EA indications?
Sir, it is usually done to evaluate between the cold and the hot nodule of the thyroid, and to also know the exact cause for the hyperthyroidism, whether it is the Graves' disease or the localized toxic adenoma, and for assessment of ectopic thyroid tissue, sir.
And this is the technetium 99 percent or iodine 125 for the radioiodine scan. Okay.
Okay, sir.
Find out the lesion, 5 common primary tumors metastatic liver.
So there's the CT scan has showing the multiple hypodense lesions scattered throughout the upper part of the liver. Then maybe the liver met, and the primary which metastasize commonly to the liver are the CRC, the colorectal carcinoma, the breast, lung, and gastric carcinoma.
Identified the structures. Star, white arrow, black arrow, and arrowhead.
Yes, sir. So these are the CT scan, CT contrast CT scan at the level of hyoid bone. So the structure marked in the black arrow is the hyoid, particularly to be at the body of hyoid. The arrowhead, the white arrowhead, is the epiglottis. The two smaller white arrows are the valleculae, whereas the other star are the epiglottic fat area. The black are the paraglottic fat space, and the white star marked are the pre-epiglottic fat space. And in the structure B, we can see that we have come down 2 or 3 slices downward. So in structure B, the arrow heights are focusing for the PFS or the piriform sinuses of the hypopharynx, and the arrows are particularly pointing out to be the AE or the ARI epiglottic folds. In
Okay.
image, okay, sir. In image C, there is the white lesion marking to be the thyroid cartilage, where the black arrows are focusing on the pointing to be at the arytenoid cartilages, and the arrowheads are pointing at vocal cord, particularly false vocal cord.
Thank you. So these are the identify the lesion, identify the scan.
This is the whole body PET scan image showing again the normal physiological uptakes in the respective body, and I can also appreciate the pathological uptake seen in the at the level of diaphragm. So these may be the GE junction tumors, sir. And based on that, there is the Sievert classification. We have the Sievert has divided the GEJ tumors based on the location. That if the location is 1 to 5 centimeter above gastroesophageal junction, it is called as the Stewart type 1. If it is located 1 centimeter above to the 2 centimeter below of the GEJ, it is called as the Stewart type 2. If it is further downward up to the 5 centimeter, it's called as the Stewart type 3. Sir.
So it is based on the histology, Stewart type, and things we can decide surgical approach, lymphadenectomy, field radiotherapy plannings, all these things are chemotherapy protocols. Okay.
Okay.
So find out this ring.
This ring is the plane of the mesorectum, sir. The yellow structure is pointing out. The mesorectum has all the important structure related to the rectum and the mesorectal fat and lymph nodes, sir. So it is the mesorectum. And sir, its significance is that it helps to identify in staging and the treatment planning. If the plane or the mesorectal or the mesorectal fascia is not involved, then it may be best to undergo for the neoadjuvant therapy. And there is CRM is the circumferential resection margin, the shortest distance between the outer part of the rectal tumor and the MRF or the mesorectum or mesorectal fascia. They are again divided into the okay.
Okay, go with question 24. What is the image showing?
Yes, sir. Sir, am I audible?
Yes. Please go ahead.
Okay, sir. So this is the Bilski MRI grading code for the ESCC or the epidural spinal cord compression. Sir, they have the three grades from 0 to the 3. The 0, 1 is for the disease is being localized to the bone only. 1 is the part where it has not upturned to the spinal cord. Means the 1A is the part where the
MRI
epidural.
grading. So when there is a need of surgery, when there is a need of radiation, we can depart based on this 0 to 3. So so all these things are to be scored to decide the surgical or radiation. This is called a Bilski score. Okay.
Okay, sir.
Okay. What is the Myrel score?
So this is the image showing the lytic lesion in the left femur below the trochanteric line. The Merrill scoring system is used particularly for the risk of pathological fractures. It has the 4 criteria.
So more than how much you should go for the stabilization?
Sir, if the total score is coming out from more than 8 means 9 or more than 9, it should be undergoed for the surgical correction. If it is less than 8, we should decide based on the performance status. Sir.
Okay. Size, lesion type, pain, and site. Okay. So more than 8 should consider for the fixation.
Yes.
Okay.
Yes.
So this is the MRI image, sagittal picture. Which sequence and what is the showing it is?
This is the MRI brain, particularly the T1 weighted one, where this is the pathway of CSF outflow, sir. The CSF is produced by the choroid plexus located on the either side of the lateral ventricle. From there, they get straight down to the third ventricle via the foramen of Monro, and from third to fourth via the aqueduct of Sylvia. From the fourth to the subarachnoid space, via two foramina. The median one are the foramen of Megendie, the lateral one are the foramen of Lashka, and from there recover to the dural venous sinuses.
So what are the CSF cytology evaluation in brain tumor where you can you have to do regularly?
So CSF cytological evaluation should be done in the tumor where the risk of leptomeningeal spread or the drop metastasis, like the medulloblastoma, as we have seen few slides earlier, also the pinealoblastoma and germ cell tumors. Sir.
So only common tumors that secondary brain tumor, secondary tumors, and metastatic to the leptomeningeal spread, you know.
So are we talking about the leukemias or?
No. The rest of the tumors spread by the cerebrospinal fluid causes leptomeningeal disease. Leukemia, that is not. I'm asking solid tumors. So mostly the breast, lung cancers, mostly though it is very rare. So mostly we seen in the lung cancer EGFR positive tumors and breast carcinomas, the leptomeningeal spread happens. So
okay.
Primary tumor, secondary tumors. So now identify this thing.
So these are the this is the mesh, the white eye reflex or the leukocoria, particularly in the pediatric patient. So this is the case of retinoblastoma, as also appreciated by the intraocular calcification in the left side of the eye, left or eye. And so the indications of EBRT are particularly the one where the margin of the optic nerve have been cut positive, and the disease is residual or recurrent after the chemo and the focal therapy. And if the disease has been extended to the bilateral or the pinealoblastoma is also there.
Identify this tumor and X-ray.
This is the X-ray of the hand, particularly appreciated by the humerus and radius ulna, with the lysis seen in the mid part of the diaphyseal region. So this with extensive soft tissue infiltration. So this may be the case of Ewing sarcoma. Sir.
Okay. So okay. So
yes.
Ewing sarcoma. What are the investigations you will
do? First, I would like to confirm my diagnosis, and by the thing for the as we have the first investigation is the X-ray of the local part, then we shall appreciate for the MRI with contrast to delineate between the soft tissue extent. Then of course, since it is a sarcoma, it has the propensity for the lung met, so we shall also order for the CT chest.
Okay. So identify the structure contoured.
So this is the image showing in the spiral structure, the temporal loop. So this may be the these are the cochlea, sir, bilateral cochlea, the petal part of temporal bone.
So you never contour should not contour the semicircular canal. So you have to contour the cochleal part only. Okay.
Okay, sir.
Any idea about the constraints?
Yes, sir. The maximum dose is constrained to be as the less than 50 gray up to 50 gray, and with the mean dose is the 45 gray.
Okay. So last image you can identify what are the this is showing 4 parts of the liver. So in where you can do the non arterial phase, portal venous phase. Sorry, what are the structures you better identify in the arterial phase, portal venous phase, and equilibrium? Just to explain the various phases and tell.
This is the CT scan, particularly focusing on the liver in the 3 famous phases. There's the arterial phase, the venous phase, or the delayed phase. The arterial phase is the phase where the post-contrast injection has been there for the period of up to 30 seconds. In the venous phase, we begin wait for the additional 30 to 40 seconds, and in the delayed phase, we get a scan of up by 5 minutes. This is better for the delineation of the HTC, as we know that HTC has a different blood supply than the normal adjacent liver, sir. It is
In
the
arterial
most of
phase,
the
after giving the contrast 10 to 20 seconds, you can see the aortic areas, muscles like supramesenteric artery, celiac artery, aortas are very good. In portal venous phase, 20 to 40 seconds, you can see the liver parenchyma, kidney, spleen. These are the solid organs you will see better. And venous structure like portal vein, splenic vein, portosplenic confluence, supramesenteric vein, you will see better. In equilibrium phase, but delayed phase, you will see the calyceal system, kidney, excretory system, you will see better way. Okay.
Okay.
So this is all about the presentations about the radiology, and many people have attended, and I thank you, Piyush, answering the questions. I have gone slightly beyond the scope, don't mind. And we are having another six exciting classes: brachytherapy, instrumentation, physics instrumentation, chemotherapy, and all these things are there. Please attend, and it will. I happy to share that all OSCE questions, most of the 80 to 90% of OSCE questions came from our PPTs in last year, and people have all attended. So please go ahead with these presentations. I will share the recordings. Utilize all these 7 days program. Hope you have all enjoyed. There will be slightly hectic 2 hours, 2.5 hours, but don't mind. It will be helpful for you. You will feel relaxed after your exam. Thank you all your attendance, and thank you for your all presence.
Thank you so much, sir. Thank you so much for having such wonderful session, sir.
So any people, anyone is interested to ask questions? So if I can ask, and we will or we'll wind up the session. If anything, any questions or any doubts, you can ask in the group also. And third thing is those people who attended, we will give the certificates at the end. And please do best in your exam. Thank you. We will don't worry, we will share the recorded sessions very soon. Nothing to worry. We will take care.
Thank you, sir. Good evening, sir.
Appreciate all the presence of Senapati sir, Laskar madam, and all faculty, Dr. Tanveer and Suparna madam. So thank you very much for your all presence and blessing the occasion. Thank you. And then we are winding up the session. Anything, any doubt, who has not received the links and everything, just let us know by directly message to me. I will upload all those things.